This is the South Texas Regional Family Medicine Grand Rounds. Oops, let me record that. Our educational partner today is the South Central Area Health Education Center. Our department's mission statement: inventing a healthier future for families and communities in San Antonio, South Texas, and beyond through excellence in patient-centered care, research, and education. Thank you in advance for muting your microphone once the presentation begins, being attentive to the presenters and engaged in the session, keeping cameras on when appropriate, registering for CME credit for each session, and for completing and submitting a session evaluation form. Today is August 23rd, and our family medicine Grand Rounds activity code is 10093211. We do track credit via the CME credit via text system. If you have not registered, please text your email address to the number on the screen, 844-502-1338, and then text attend 10093211. You must register for each session by midnight in order to receive CME credit. Here's some information about the CME system, which we've already gone over. Again, that code is 10093211. You can access your CME transcripts through the Long School of Medicine CME website, cme.utesca.edu. And you can also claim credit for this activity via the AAFP credit system. The FCM Grand Rounds address nationally established physician core competencies, including the Institute of Medicine core competencies, the ABMS/ACGME competencies, and the AAMC competencies. Our speaker today, Dr. Pankaj Madan, MD, has no financial relationships with ineligible companies to disclose. And Dr. Shi will present the speaker.
Okay. It's my pleasure to introduce Dr. Madan here today. He is a funding medical director of the Adult Congenital Heart Disease program at the University of Health. He completed his internal medicine residency at Baylor College of Medicine in Houston. While completing his fellowship in cardiovascular disease at University of Washington, he also earned a Master of Science degree in epidemiology at University of Washington School of Public Health. I thought that was pretty neat. He completed an additional fellowship training in adult congenital heart disease at the prestigious Mayo Clinic at Rochester, Minnesota. Dr. Madan's main area of clinical practice are management of patients with adult congenital heart disease, cardiovascular genetics, management of cardiovascular disease during pregnancy, Marfan syndrome, and inherited arthropathy. Am I saying it right? Okay, sorry. Here, without further ado, let's hear that.
All right.
Thank you.
Thank you. Thanks for having me here. Thanks for the kind introduction, Dr. Shi. Can everybody hear me in the back? We don't have a mic here.
I don't think, is anybody online?
Yes, there are a few. They should be able to pick up just fine from there.
Okay.
Okay, perfect then. So I'm going to start by first defining the adult congenital heart disease population. So roughly 40,000 infants are born annually in the United States with congenital heart defect. As the management of congenital heart disease has progressed, the management of congenital heart disease patients has always been a moving target. When the congenital heart surgery was first being invented and being done, the initial goal for the surgeons was that the patient should survive the initial surgical repair, should make out of the OR. And then it became surviving till 1 year of age, and then finally it became having a normal childhood, and then it became adolescence. And then more and more patients started to survive till adulthood. So they started to say, like, okay, how the patients are surviving till the age of 18 years. And the goal of my specific subspecialty is for these patients to survive through adulthood. So the survival of congenital heart disease patients has been improving every decade. For example, if you were born in 1940, only 20% of the patients were expected to survive in adulthood. And if you were born in 1990, then more than 90% of the patients are expected to reach 18 years old. So more and more surviving to adulthood is now expected for the congenital heart disease patients. This has led to a changing mortality patterns in patients with congenital heart disease. On your left side is the year 1987, 1988. On the x-axis is the age at death. I'm sorry, on the x-axis is the proportion of all deaths. On the y-axis is the age at deaths. If you look at the year 1987, 88, a significant number of patients were still dying at less than 1 year of age in the 1980s, versus very few patients now dying in the childhood, and the mortality patterns have now shifted towards the adult age group. So there is an increasing number of patients, and these patients are getting older as we follow them in the clinic. So this has led to the changing demographics in patients with congenital heart disease. In 1965, majority of the patients were in the pediatric age group. 70% of the patients with congenital heart disease were children. Only 30% of them were adults. By 2000, this population was evenly split between the adult side and the pediatric side. 50% adults, 50% children. And now more than 60 to 70% of the patients with congenital heart disease are adults. The pediatric congenital heart disease is more of a minority in the bigger scheme of congenital heart disease. So there are roughly about 1.4 million patients living with congenital heart disease that are adults in the United States. And to this population, we add about 40,000 new patients every year. And there are more adult patients with congenital heart disease than pediatric patients. So you're going to see them. About of all these patients, 55% of them have moderately to greatly complex congenital heart disease. And those are the patients that definitely need our help. So what is the problem? The problem is, no surprises, that these patients have reduced survival when compared to patients who were born with no hearts. If you look at about 20 years of age until what the pediatricians are following, there's about a 5% gap between a normal healthy patient who was born with a fourth-generation heart to a patient who was born with a congenital heart defect. But then these curves tend to widen over time. And by the time you hit 50, 80% of the patients will hit 50 years of age, versus more than 90% of the patients in the general population who are going to be hitting 50 years of age. So there's about a 10% difference right there. And the more severe form of congenital heart disease you have, the worse is you're going to be long-term outcome. So if you're comparing to an atrial septal defect, which is the top line, then about 90% of the patients are going to be making up to 50 years of age. But if you have severe forms of congenital heart disease, the chances of you making up to 50 years of age is about 50%. So a lot of the greatly complex patients are going to die before they hit 50 years of age, which is still pretty young. So what is the mortality in adult congenital heart disease due to? No surprises there. The majority of the mortality in the congenital heart disease patients is largely cardiovascular, which may be heart failure, which is a big chunk of it, vascular complications, arrhythmia is big complications. So these are some of the challenges that we see in the clinic when the patients are long-term survivors of congenital heart disease. About a quarter of these patients will die from non-cardiac causes. So as I said, that majority of the mortality is related to cardiovascular causes. This is on the y-axis are the different forms of congenital heart defect. This is patent arteriosus, which is which we classify as a simple congenital heart defect, and over here, complete ventricular heart, which is a more complex form of congenital heart disease. So as you go down this pathway, you are seeing more and more complex heart disease. So the contribution of cardiovascular mortality to congenital heart disease keeps on increasing. In terms of cardiovascular mortality, the majority of the deaths are due to sudden cardiac death. I am in the clinic, I will get a call from the coroner office, so and so the patient died suddenly or didn't wake up from sleep, and it's hard, but this is how life is, and there is no easy way to predict who is going to die, and that's one of the things that we grapple in the clinic. Patients come to the hospital or to the clinic with heart failure exacerbation, so that's another big reason why they come to us. Perioperative mortality is also common, particularly in patients who are born blue or have severe pulmonary hypertension. So it takes a lot of effort to coordinate their care across multiple specialties with appropriate anesthesiologists and education to ensure that they don't die from the perioperative causes. So those are some of the things that we see in the clinic, and those are the major causes of cardiovascular mortality in adult patients with congenital heart disease. Not only mortality, there's tremendously increased morbidity in patients with adult congenital heart disease. This is data from Canada. So if you typically, if you have a mild to moderately complex heart disease, you have 2 times the rate of hospitalization when compared to age and gender matched controls of normal population. If you have severe congenital heart disease, your hospitalization rates are 3 times when compared to the normal population. The hospitalizations for adult congenital heart disease are increasing in the United States every passing year. So you will see that in 1990. So the light bar is the pediatric hospitalization. The dark bar is the hospitalizations in adult survivors of congenital heart disease. So you can see that the pediatric hospitalizations have sort of plateaued in the last several years, but the adult congenital heart disease hospitalizations keep on increasing every single year. So what I have shown so far is that once reaching adulthood, survival is not as expected for patients who are adult survivors of congenital heart disease. The heart failure and arrhythmia burden is significant, and the morbidity is substantial. And the long-term complications of adult congenital heart disease can be several. These are all the cardiovascular long-term complications. They can have arrhythmias, atrial arrhythmias, or ventricular arrhythmias. By the time congenital heart disease patient hits 70, there's an 80% chance that they already have some sort of arrhythmias. They have ventricular arrhythmias. They are prone to sudden cardiac death. They have vascular lesions in form of pulmonary artery stenosis, or the stenosis in the different blood vessels, as well as pulmonary hypertension. There's a huge burden of valvular heart disease in the patient because of the genetically malformed valves that they are born with, or because they got prosthetic valves from the surgeon as a child. There is residual shunts because of the sequelae of prior surgery when the surgeons connected the arteries to the pulmonary arteries, aortic from the different kind of shunts that they get, or from previous period regions. Heart failure burden is significant, as I mentioned. So, if you look at the sudden cardiac death in adult congenital heart disease patients, it varies depending upon what kind of congenital heart defect you have. It is low if they were just born with a small VSD, and it is very high if you were born with moderate to greatly complex congenital heart disease, such as tracheal flow or transposition of arteries or congenital aortic stenosis. Similarly, the prevalence of atrial arrhythmias also varies depending upon the congenital heart defect. It can be low in a patient with glomerular stenosis, but it can be very high in a patient with a single ventricular physiology that has been validated with Fontan or somebody with transplantation data is with muscular procedure. So, and that is why we have appropriate screening, disease-specific screening criteria in the clinic so that we can detect their arrhythmias while they are asymptomatic. So these patients are also not immune to developing adult onset comorbidities such as coronary artery disease, vascular disease, cerebrovascular disease, diabetes, obstructive sleep apnea, COPD, renal anticoagulation insufficiency. In fact, the prevalence of metabolic risk factors is much higher in adults with congenital heart disease because as a child they have always been told to take it easy and have been barred from playing in the sports and so they have lived a very sedentary lifestyle which only makes the presence of metabolic factors only worse. This chart shows how tremendous the morbidity is in patients with adult congenital heart disease. So this is an average adult congenital heart disease patient, and there is about a 75% chance that by the time they hit 50 years of age, they would have either had a non-fatal myocardial infarction, a stroke, atrial fibrillation, or died. So beyond that, they have a significant comorbidity. So I would like you to think of congenital heart disease as a multi-system disorder. And I'm going to spend some time on this slide because congenital heart disease affects practically all body systems, and it affects the body systems in ways that that you do not encounter in the general population. Okay, so for example, if you talk about pulmonary system, people have undergone a lot of surgeries in the past, so they always have some sort of restrictive pattern on the spirometry whenever you test them. There is pulmonary hypertension, which affects 10% of the patients with congenital heart disease. Pulmonary hemorrhage can happen because of elevated pulmonary hypertension. Plastic bronchitis is another rare complication, particularly in patients with single ventricle who have been palliated with Fontan. Liver problems are common because of congestive hepatopathy from the right-sided heart disease. Cirrhosis can happen, and because of the nature of cirrhosis that has been long-standing, hepatocellular carcinomas can also develop. And so these are some of the, again, in single ventricle patients, we have protocols to screen them for the liver disease on an annual basis. When we talk about infectious disease, brain abscess in patients who have unrepaired shunts and who have cyanotic heart disease are common. If you have a patient who is complaining of unexplained headache and who is cyanotic, who has Eisenmenger syndrome, have a very low threshold to scan this head to rule out brain abscess. Infective endocarditis is the bane of our existence. Patients who are not very good with the oral hygiene, they are going to have, they will develop infective endocarditis because they already have a nidus in form of abnormal cardiac anatomy. It is important to know the indications for infective endocarditis prophylaxis and appropriately use them prior to dental cleaning. Protein-losing enteropathy is probably one of the most feared complications in patients with single ventricle. In the protein-losing enteropathy, you lose albumin through the gut, and it's very hard to treat. Patients swell up and their albumins are like 1.5. It's often, once you have it, the mortality from it is about 50% over the next 5 years. We tend to send these patients for transplant. From the hematology standpoint of view, these patients have secondary erythrocytosis because your oxygen saturation is often below 90% resting. So these patients, the body has done secondary erythrocytosis. It is important that these patients undergo regular iron checkup or iron studies. For example, if you have a patient who have a 85% oxygen saturation at baseline, hemoglobin of 12 is not normal in such a patient. This patient should have a higher hemoglobin to compensate for the level of cyanosis that they have. So 12 grams in a patient with 85 saturation can be related to iron deficiency anemia. Treatment of iron deficiency anemia is important because iron deficiency anemia in these patients is a risk factor for stroke. So simple things that you can do that are going to prevent these patients from ending up in the hospital. And similarly, the people who are who come to the hospital with GI bleed, and you see a patient who has an oxygen saturation of 83% baseline, and their hemoglobin is now 9 after a GI bleed. Have a low threshold to transfuse that patient. Do not go by the standard guidelines of hemoglobin 7 or 8 to transfuse that patient, because that patient probably needs to be at a higher hemoglobin level to have appropriate cardiac function. Okay. So important to know the baseline hemoglobin and important to periodically check for iron deficiency anemia. Hyperuricemia from the increased turnover of the blood cells. There's an increased thromboembolism risk. And when we talk about oncology issues, you will realize that these patients undergo a lifetime of cardiac catheterizations, a lot of CT scans. And so over years, the ionizing radiation that these patients have been receiving adds up. And we anticipate that some of the malignancies in congenital heart disease population are a risk directly attributed to the cumulative dose of radiation that they have received in the past. Some of the associations with cyanotic heart disease are also genetic because it triggers some sort of genetic pathway, and patients are also prone to developing pheochromocytoma. We discussed about hepatocellular carcinoma in patients with liver dysfunction. So right now the guidelines only ask for age-appropriate cancer screening, but no special otherwise for patients with congenital heart disease. About 30 to 40% of our patients have psychosocial issues that are related to depression, anxiety. They frequently have neurodevelopmental deficits as a result of their prior surgeries or just because of their condition. When it comes to endocrinology issues, hypothyroidism is pretty common. Patients with cyanosis have osteoporosis and have scoliosis, and that happens. Diabetes is overrepresented in this population, and so is dyslipidemia. When it comes to renal system, cardiorenal system is pretty common. Patients have increased proteinuria and are prone to developing chronic kidney disease in the future. When it comes to vascular complications, cerebrovascular disease happens at about 3 to 5 times the rate of normal population. Peripheral vascular disease is common because of the previous catheterizations have taken down their femoral arteries or the brachial arteries. Aortic dilatation or aortic aneurysms are common. Endothelial dysfunction is common at the vascular level, and hypertension is also prevalent. In an adult congenital heart disease, some of the issues happen on a regular basis. One of them is that patient comes to you and they actually have history of cardiac surgery, congenital heart disease, but they actually do not know what they have got. So, and sometimes you have to use your best judgment and use whatever resources you have to put together a more cohesive history. For example, a 24-year-old female with congenital heart disease presented with shortness of breath. She had prior history of surgical repair. And often in these patients, we are taking histories and we are asking, okay, when you were born, were you blue as a child or not? So that helps us figure out whether this was a problem of reduced pulmonary blood flow or a patient who had increased pulmonary blood flow when they were born. So patients who had reduced pulmonary blood flow, they are not able to get oxygen because there's no increased pulmonary blood flow. So these patients are blue. And the cyanotic patients usually have tetralogy of flow, transmission rate arteries, total normal production. And then there is another subset of patients who are not blue, but they have complaints of big heart failure as an infant, so nobody has like orthopnea, the kids don't complain of it. But what you are looking for history is history. If they had trouble breathing as a child, would they always want it to be propped up on the shoulder, or you hold them flat? So firstly, they be increased respiratory infection as a child, even all the signs of pulmonary overcirculation in heart failure. So in these under this category are the classic lesions, the shunt lesions, which is ventricular ductal defect, atrial septal defect, patent ductus arteriosus, or partial anomalous pulmonary shunt. A simple chest X-ray can actually be very helpful in figuring out what the patient has, and can sometimes give you a very recent story. This is the chest X-ray of the woman that we discussed. So what we see is, lungs, heart, but what we see is a device here, and it has 3 leads in there. This is the oil, so which means that this patient has an ICD. So then we check out then there is ICD. There is sternal clips here. It confirms with the sternal wires and everything, so open heart surgery. And then over here we see stent here or a valve here. This is the pulmonary artery, and this is the appearance of a pulmonary valve which has been placed by transcatheter valve. And then we're looking at the cardiac silhouette. This is what right ventricular hypertrophy looks like by looking at the angle between the diaphragm and this part of the heart, which is acute. In a normal heart, it's an obtuse angle. This is indicated right ventricular hypertrophy. So this patient had tetralogy of flow, so that's how tetralogy of flow X-ray looks like when it has been repaired. And patients, so I'm going to discuss tetralogy of flow in a little bit later, but that's how it looks like. So tetralogy of flow, most common form of congenital heart disease. This is like, I can see an entire day tetralogy of flow in the clinic. It's the most common congenital heart disease patient in our clinic. There is not a day where we do not see tetralogy of flow. So in the tetralogy of flow, there is a large VSD and there is a narrow pulmonary valve, and pretty much the entire physiology is dependent upon these 2 conditions, even though we talk about the 4 things associated with tetralogy of flow. So when you have a narrow pulmonary valve and with a VSD, the blue blood cannot go to the lungs, so it has to obligatory go through the ventricular septal defect mixed with the red blood on the left side, and it goes through the aorta, and the patient is healed, right? So the surgery of the tetralogy of flow is aimed at fixing this defect. So the surgeons will put a patch to close the VSD, and then they will open up the pulmonary artery by splitting it up and putting in another patch, which is called the transcanular patch. The main complication of this kind of procedure is that we now often exchange a narrow pulmonic valve for a leaky pulmonic valve. So we replace the stenosis with regurgitation in the pulmonic valve. And the good news is that pulmonic valve regurgitation can be tolerated in a child for decades. In fact, people didn't even think that was ever going to be a problem. But in the adult life, often this pulmonic valve regurgitation leads to progressive right-sided enlargement, right-sided failure, and often we end up replacing it. Okay, so in the chest X-ray, that patient had the pulmonic valve replacement. Okay, so sometimes we do not even have chest X-rays to look at. So we are in the clinic, we are taking histories, and then we are trying to make a diagnosis based upon the initial clinical presentation. And we have the stars to guide us what kind of surgery might have happened in the past. So we are looking at thoracotomy styles. We are looking for left thoracotomy. So there are certain surgeries that can be done through left thoracotomy, which is the classification, coarctation repair, PDA ligation, vascular vein division, PA banding, portion. Here, portion and vascular vein division are not very commonly seen, so we have pretty much have like four things to figure out of this one of these four. And on the right, thoracotomy, again, the VT shunt is still common. Waterston is not longer there. The ASC and simple heart defect can happen. So we're looking, if you have a thoracotomy scar, either it's a VT shunt or some sort of coarctation repair, but coarctation repair is done to the left side. So it helps to narrow down some of the differentials as we see them in the field. Okay. And then, of course, cardiovascular examination comes in handy the more you ask them. And of course, echoes in the clinic, so we know that. So one is to put their histories together to figure out what exactly that they have. The second issue in our clinic is that people come often with inappropriate medical advice or they have been treated inappropriately. Like, for example, I saw a 56-year-old woman. She was born with tetralogy of flow. She had undergone previous surgical repair, and the main issue for her was that she had hypotension, or that's what she thought. And she was being treated by her internist by increasing the salt intake, by giving midodrine, and somebody thought that she had adrenal insufficiency, so they were also applying her with a lot of steroids. The problem is that she had undergone what we call as classic Blaylock toxic shunts. Okay, so what is a BT shunt? The BT shunt is so remember that tetralogy flow. I showed you the diagram. It's the problem of less pulmonary blood flow. This local is pulmonary cirrhosis attached to it, right? So in when you have an older patient, the surgeons often did what they call as a Blaylock toxic shunt in order to improve the blood supply to the lungs. Okay, so they took down the subclavian artery and attached it to the pulmonary artery directly. And in that case, they did it on both sides. So they would classic VT shunt on the right side and the left side. So once you have sacrificed the subclavian arteries, you are not going to have pressures in your arms, no matter how hard you try. Okay. So, but the femoral pressure in that moment was more than 200 systolic. Okay, so you have to say, okay, now everybody's trying to push the blood pressure to 200, which is not right. So we have to dial down all those therapies back and tell them that anytime somebody asks for his monitoring your blood pressure, you have to make sure that they monitor it in the leg. You have to be supine. That's how we're going to monitor your blood pressure. Actually, the patient is on antihypertensive now. Okay? So, two of them. But these things are not common. Okay. The third thing to realize is that you will see these patients in the clinic and they tell you that they are doing well and they don't have any symptoms, and then it holds you back that if they're doing well, you might send them to a cardiologist. Okay? But I want you to still send them to cardiologists, because people who have born with like a complex medical condition since birth, they actually do not know what it is to be feeling normal. And this is why I showed you this graph. Again, different forms of congenital heart disease, and patients were put on a treadmill, and their exercise capacity was measured. This is the normal. Virtually all categories of patients with congenital heart disease are not normal. They do not have a normal exercise capacity. Okay, so and they don't even realize it. By the way, in this study, all of these patients said that they are doing well, but they're not. So we can help them. So adult congenital heart disease population is a high risk group of young adults and now getting older adults, which requires specialized and multidisciplinary care. But who is providing the care? So many of them are seen by the pediatric cardiologists who have more expertise in adults with congenital heart disease. Many are also seen by the adult cardiologists but who do not know about congenital heart disease. I went through cardiology fellowship training. As part of our training, we are only supposed to hear about 6 hours of lectures in congenital heart disease, but beyond that, we're not expected to do anything else. That's the ACG requirement. So, and then few of them are being seen in the dedicated adult congenital heart disease clinics, and several have been lost to follow-up. Okay? So, if we estimate about 800,000 people with complex heart disease in the United States, less than 10% of actually are being seen by an adult congenital heart disease cardiologist. So there's a large number of patients in the community that are not being seen by the specialists. Okay, and it is important to understand why these patients have been lost to follow-up. Okay, so if you started with about 100 patients with congenital heart disease as a pediatric cardiologist, by the time you hit this 18 to 40 years, 60% of the patients have already fallen through the cracks, even if they have as a child. Okay, so the good news is that 90% of these patients will have some form of connections with the healthcare system. They still think they're trying to get doctor, even if they're not seeing a cardiologist. So we are relying on the internists to get them back to the cardiologist whenever you see somebody like that. So we need to tell them, hey, you have a cardiologist, you get a cardiologist. Okay. So what are some of the reasons for being lost to care? There are some patient-related obstacles. There are some physician-related obstacles. From the patient standpoint of view, the patient assumes that, okay, they have been fixed as a child. The surgery has already happened. I am cured. There is poor communication from parents or the pediatrician. The health records have been lost. And the symptom onset is so gradual that you do not even notice that there is a problem. Patients also fall off the doctor's thing because they lose health insurance. And then there are physician-related obstacles too. Physicians assume cure. They are informed about future potential problems. They have no records available. The patients do not report any symptoms, like I told you. And if they have symptoms, then they are ascribed to more common causes. Okay. So we covered the recurring themes. So when we talk about congenital heart disease broadly, people have sat down and divided them into 3 major groups. One is simple heart disease, which I'm going to go through. So if you have an unrepaired condition, which is a small isolated ST, small isolated VSD, maybe mild pulmonary stenosis, or if you have a previously repaired condition such as a patent depressed arteriosus, if it's at a V-type VSD, or you have isolated valve disease such as aortic valve disease, myocardial disease, or isolated patent form and well. The guidelines state that these patients should be seen at adult congenital heart disease at least once, but most of the time these patients can be taken care of by a general cardiologist. So this list is longer, and this consists of moderately complex congenital heart disease. I'm going to go through them, and you may recognize some of them from the medical school. And these are anomalous left coronary artery rising from pulmonary artery, anomalous pulmonary venous drainage, partial or total anomalous pulmonary venous drainage, posterior prinum or sinus venosus ASD, coarctation of aorta, Epstein anomaly, infundibular right ventricular outflow tract obstruction, pulmonary valve vegetation, pulmonic valve stenosis, sinus of valve salva fistula or aneurysm, subvalvular or supravalvular aortic stenosis, tetralogy of flow, PSC with any valve problems. These patients should be seen periodically at adult congenital heart disease centers. We sometimes will share here with the general cardiologist, but majority of the patients tend to gravitate towards this anyway. Then the list becomes even longer. These are greatly complex congenital heart disease. Some of these diseases are like the lifetime diseases when you're seeing like in a family medicine clinic. You may see them once in several years, even though at our clinic we may see them
on a routine basis, okay? I'm going to go through this list. You don't have to memorize this list, okay, but let's go through it one time. So congenital corrective transposition of great arteries, double outlet ventricle, mitral atresia, pulmonary atresia, pulmonary vascular obstructive disease, Shone's complex, single ventricles of all forms, transposition of great arteries, tricuspid atresia, truncus arteriosus, other abnormalities of AV connections such as Lisbos, isomerism, hypotaxy, and all the patients who have undergone the following procedures: arterial switch procedure, Blaylock cross-sections, any conduits, double switch procedure, Fontan procedure, Mustard procedure, Norwood procedure, Raster procedure, Sandy procedure. Even cardiologists do not know what they are dealing with, okay? And all patients are blue, all patients with Eisenmenger syndrome. These patients should be regularly seen at the congenital heart disease clinic. We are the primary people. We everything goes through us. Whatever needs to happen goes through us. Okay. So those patients should be best served by us for the internal medical needs. Okay. So if you do not remember any of the things that I told you, just remember these 4 points, okay? So when to refer, if your patient had a surgery named after a physician, fantastic, that's a good chance to refer, okay? When more than isolated congenital structural heart defect is present, just send the patient, okay? You can't figure out an artery in 5 seconds of listening the diagnosis. I think it's a fantastic time to refer. And if you have a congenital heart disease patient that has never been seen by an ACHD cardiologist, refer. Okay. So, and referring to adult congenital heart disease center actually saves lives. So this is a year. This is the patients who were referred to the adult congenital heart disease center, and these are the deaths. This light bar is the deaths per 1,000 population per year. So the original guidelines, the first guidelines for care of adult congenital heart disease actually came in 1998. And once those guidelines came about, then there was a huge referral. There was people started sending patients to the adult congenital heart disease center of excellence. So this line started going up. So that's where the change point was. And 1 or 2 years later, the patient's mortality rate started declining once the experts were taking care of this population. And patients who are taken care of at a referral center, they have a better long-term survival when compared to patients who are not being referred to the referral centers of excellence for adult congenital heart disease. So bottom line, recognize the potential for long-term complications, which is arrhythmia, endocarditis, and hemodynamic issues. Recognize that your patient may be uninformed, won't always tell you the correct diagnosis. They may tell you that, oh, I just had a month, nothing more, but I have like 3 surgeries in the past. Recognize that the patient may be asymptomatic, but will be abnormal when we test them formally, and ask for help with congenital heart disease patients, whether clinical encounters, imaging, or procedures. Sending patients to our clinic is very easy, particularly if you're on the university health ethics system. If you put a referral to cardiology, then this pops up, and you just click, I'm going to refer to adult congenital cardiology, and then send, and it goes to our clinic. Okay. We don't have a similar order on the UT side, but we're working on it. And if you can't use that, then my cell number and my email on the YouTube email is another way to reach out to me. Okay. That's it. Questions, concerns?
So you had mentioned that this protein losing enteropathy that they get, and I think you said that one of the treatments, important treatments, is transplant for that.
Yes.
But once they have the protein losing enteropathy, how does the transplant help the enteropathy?
Because, so the question is, so we do a lot of medical management. The protein losing enteropathy is significantly found in a subset of population, which is the univentricular heart within the modern population. What happens when you have a patient with a single ventricle with a content? These patients do not have
the right ventricle near to one part. So in this patient population, we are the surgeons to construct what is called the content simulation, in which the IVC is hooked up directly to the pulmonary artery underneath it, and the superior vena cava is also hooked up to the pulmonary artery. So to drive the blood through the pulmonary vasculature, because there is no pump in general, because there is no ventricles, the SVC and IVC will have to generate higher pressures in driving across the pulmonary vasculature. So all that central venous pressure somehow affects the whatever the digestive system or the lymphatic system, and it causes increased pressure in them, and then we start losing protein. So by putting the patient through transplant, what you're hoping to accomplish is more of a normal circulation, that you can put the SVP and IVC in a normal heart, and then reduce the central venous pressure driving to the pulmonary vasculature, and hopefully cure the venous control.
Yeah, so you had mentioned, I can't remember the number, but it was over 1 million of these patients in the US, is that right?
Correct.
So they should all go to the clinic, right?
Yeah.
But are there really enough clinics for 1 million in some patients?
No. But you sending us the supply generates the demand for the specialists, especially. So if you work on the supply side, we'll work on the demand.
So you had mentioned some of the patients don't die in infancy, I guess, right?
Yeah.
Or there's mostly like hypoplastic left heart.
Yeah, hypoplastic left heart, more complex forms, yes. Yeah. But the hypoplastics are also living up to 90% survival rate. Or IATs actually.
We're talking about the anemia, the iron deficiency, and transfusion, like thresholds, I guess.
Yeah.
What would be their threshold if we're not going by the 8? Is it just looking at their baseline, and if they're completely deviated from that? or-
Yes, yes. So what you have to, there is no specific threshold, because patients, like I have seen the oxygen saturation in my clinic as low as 65, and talking to people, patient with cardiac arrest. So, and his hemoglobin runs like 22. Right? And he's blue as a smart, right? And so everybody's threshold is different. So what you have to look at is their last hemoglobin, historical hemoglobin, and look at terms in that way. So and you have to just make sure that their iron replete neither above target or this thing. The body somehow will adjust their hemoglobin to the whatever they need. Yes.
So, I don't know if were you ever in the military?
No.
So if you're in the military, a lot of the units will have their own coin.
Okay.
So that's a tradition we brought here. So we have our own coin. It's just, it's not as much as giving you a plaque, but it's a little more,
I'll take it.
a little more than, yeah, a little more than just a handshake
Yes,
anyway, right? So
absolutely.
I'll give you a handshake, but
Okay.
also, this is the highly sought after, seldom presented, but always treasured Family and Community Medicine Challenge coin. So thank you very
so
much. Yeah.
That's it. Thank you for having me, and that's it.